Hello friends, this is Nishant Gautam, Associate Professor from the Department of Pharmacology, Laureate Institute of Pharmacy. Today we will continue the chapter Plasma Volume Expenders. We already studied its a part 1. Today we will discuss the same chapter in its a part 2. As we know, this chapter belongs to your second unit, Pharmacology of the Drugs Acting on Cardiovascular System. As we already discussed the two types of the colloids, one is the natural colloids and another is the synthetic colloid. So we will start with the first natural colloids, that is the human albumin. Let us discuss about some important facts of the human albumin. The human albumin is most abundant protein in human plasma, that is 40 to 50 gram per liter, with a total body content of 4 to 5 gram per kg. The second important fact, the human albumin is hydrophilic, non-glycosylated protein with a molecular weight of 69 kilodalton. Also, the human albumin is distributed 1/3 to 2/3 in the intravascular compartment relative to the extravascular compartment, and it accounts for 70 to 80% of plasma colloid oncotic pressure. The human albumin having the capacity to bind cation, anion and toxins such as bilirubin. With this, the human albumin gives an important physiological role in buffering the acid-base balance of the blood. Also, it plays important physiological role in regulating the ionized fraction of cation, including the calcium and magnesium. It also having some important physiological role in scavenging free radicals, transporting proteins and drugs. The sixth important factor is the human albumin synthesized in the liver with a mean half-life of 14.8 days and is degraded mostly in muscle, liver and kidney. The human albumin shows hypoalbuminemia from a range of pathologies, is a poor prognostic factor. In addition to this, the human albumin is obtained from pooled human plasma. The human albumin can be used without regard to the patient's blood group and does not interfere with the process of coagulation. Human albumin is free of risk of transmission of the hepatitis because the preparation is heat treated. This is the structure of the albumin. Further, the human albumin has been used in acute hypoproteinemia, acute liver failure and dialysis. The human albumin is comparatively expensive. Here are some available products of the human albumin preparations. They are the Albudac, Albupam, 50 or the 100 ml injection. and the albumin 5% and 20% infusion in the 100 ml. The dilution of blood using albumin and crystalloid solution can be used before cardiopulmonary bypass also. The human albumin also available as iso-oncotic 4% to 5% solutions for intravascular volume expansion, and as hyperoncotic solution 20 to 25% for the maintenance of fluid balance between compartments and the restoration of CO. Also, humans albumin positions as a benchmark biological therapy in terms of pathogen safety remains unchallenged. As an additive stabilizer for the other therapies such as recombinant protein and monoclonal antibodies, and the so-called as the new generation formulations of these therapies, which exclude albumin in the context of enhanced safety, are addressing perception rather than real risk. The another colloidal preparation as a plasma volume expenders is the dextrans. The dextrans are the groups of branched polysaccharides derived from the sucrose, mainly of beetroot, by the action of the bacterium Leuconostoc mesenterioids. The dextrans are the preparations of polydisperse mixtures grouped on the basis of their average molecular weight, which is different from the average molecular weight of the particles with colloid oncotic power, which is important for their hemodynamic action. The main two types of the dextrans are clinically utilized as a plasma volume expander are the dextran 40, available as a 10% solution in dextrose or saline. The another is the dextran 60 and 70, prepared as a 6% solution in dextrose or saline. Mostly for the clinical purposes, dextran 40 and dextran 70 is utilized. The molecular weight of dextran is the chief determinant of the pharmacodynamics. Now, let us discuss the important facts of the plasma volume expander, that is the dextran 70. The dextran 70 is most commonly used preparation clinically. Dextran 70 expands plasma volume for nearly 24 hours. Dextran 70 is excreted slowly by glomerular filtration as well as oxidized in body over weeks. The dextran 70's some amount is get deposited in the reticuloendothelial cells. This commonly used preparation, dextran 70 as a plasma volume expander, has nearly all properties of an ideal plasma volume expander, except the dextran 70 may interfere with the blood grouping and cross match is the biggest disadvantage. Another thing, the dextran 70 can interfere with coagulation and platelet function, and thus prolong the bleeding time is another important disadvantage. In some cases, what happens if the polysaccharide reacting antibodies are present, they may cross-react with dextran and trigger the anaphylactic reaction like urticaria, itching, bronchospasm, or may the fall in blood pressure. Then the second type of the dextran preparation is the dextran 40 as a plasma volume expenders. The dextran 40 is the 10% solution in dextrose or saline. The dextran 40 acts more rapidly than that of the dextran 70. The dextran 40 reduces the blood viscosity. The dextran 40 is mainly excreted through renal tubules and occasionally may produce acute renal failure. The total dose of dextran 40 should not be exceed than the 20 ml per kg in 24 hours. Dextrans can be stored for 10 years and are cheap, so are the most commonly used plasma expenders. The caution behind the dextran is that the dextran doesn't provide necessary electrolytes, and so they may cause the hyponatremia or other electrolyte disbalances in the body. So this is the major disadvantage behind the use of this dextran clinically, that they cannot balance the electrolyte as per the requirement of the body. Then let us discuss about the another choice of the preparation as a plasma volume expender, that is the degraded gelatin polymer or the polygylene. The polygylene is a synthetic polymer or the polypeptide of molecular weight 30,000. Polygylene is doesn't interfere with blood grouping and cross matching and is also non-antigenic. This is the major advantage of the polygylene. The polygylene expands plasma volume for 12 hours. The polygylene is more expensive than that of the dextran and can also be used for priming of heart lung and dialysis machine. The brands of polygylene available in the market for the clinical purposes are the Himacil and Saracil in the 50 ml preparation. This 50 ml preparation is available as the 3.5% solution in balanced electrolyte medium. Then the next choice for the therapy as a plasma volume expender, the hydroxyethyl starch, also called as the HATA starch. The HATA starch is a complex mixture of ethoxylated amylopectin of various molecular size. The average molecular weight is 4.5 lakh. The HATA starch maintains blood volume longer. The HATA starch doesn't cause acute renal failure or coagulation disturbances. The HATA starch improves hemodynamic status for the 24 hours. Now let us discuss the adverse effects, brand available of the HATA starch and the use of the HATA starch. Now start with the adverse effects. Vomiting, mild fever, itching, chills, flu-like symptoms, swelling of salivary glands, urticaria, bronchospasm, anaphylactic reactions, periorbital edema, etc. are the adverse effects of the Hatta starch. The brand available of the Hatta starch in the market is the Expand 6% injection, available as in the 100 or the 500 ml vial. The Hatta starch has also been used to improve harvesting of granulocytes because it accelerates erythrocyte sedimentation. Then the another plasma volume expender is polyvinyl pyrrolidine, abbreviated as PVP. The polyvinyl pyrrolidine is a synthetic polymer of average molecular weight 40,000. It is used as 3.5% solution. Polyvinyl pyrrolidine was used as blood plasma expender for trauma victims after the 1950s. The polyvinyl pyrrolidine is the oldest plasma expender and having some disadvantages that it interferes with blood grouping and cross matching, and also it is histamine releaser. And the major disadvantage of this polyvinyl pyrrolidine is that it binds with that of the penicillin and the insulin. So nowadays clinically it is rarely used. In addition to this, the polyvinyl pyrrolidine is excreted by kidney and small amount by liver into the bile. The fraction of pyrrolidine is stored in reticuloendothelial cells for a prolonged period. The polyvinyl pyrrolidine is less commonly used plasma expenders. Now, let us discuss about some another uses of polyvinyl pyrrolidine is used in the personal care products such as shampoos, toothpastes, hairsprays, and gels. The PVP is used as binder in many pharmaceutical tablets. The polyvinyl pyrrolidine added to iodine forms a complex called as the povidone iodine that possess disinfectant properties and known under the trade name of betadine and iodine. Now, let us discuss about some adverse effects of the synthetic colloids. These synthetic colloids produces some severe adverse effects like coagulopathy, renal failure, circulatory and hepatic complications. Among all these adverse effects, the coagulopathy and the circulatory complications are the major adverse effects. As we know, the use of plasma volume expenders are responsible for the increase in the volume of distribution. By the use of these fluids other than the fresh blood may be expected to lead a progressive dilution of the cellular and the protein hemostatic components. Among these components, mainly the two anticoagulants as well as the procoagulant proteins. And if we will monitor these two with the help of thromboelastogram, that is the TEG, it shows that acute hemodilation with saline induces a hypercoagulable state. It is probably because of the dilution of antithrombin 3. The mechanism of antithrombin 3 we already made discussion with the chapter coagulants and anticoagulants. The antithrombin 3 is the most important physiological anticoagulant which has a high normal range, that is in plasma levels of 80% to 120%. In addition to this, some adverse effect of individual synthetic colloids are the hemodilution as a result of albumin infusion leads to in vitro coagulation abnormalities at 30% volume replacement, but is not considered to have clinically significant effects. Whereas, on another hand, the gelatin has induced post-operative hypercoagulation following joint replacement surgery and results in decreased TEG measured clot strength. It also impaired platelet aggregation in normal volunteers and during cardiac surgery. The third one, dextran and hydroxyethyl starch molecules exert an effect on both primary hemostasis and coagulation through a drop in the factor 8 and 1 Willebrand factor complex, which is higher than predicted through dilution. The incidence of acute renal failure associated with dextran and hydroxyethyl starch has also been reported. So that's all for the day. We will continue the same chapter in part 3. Till then, revise the topic from the book. Have a nice day and thank you.